amount. The first speaker is Catherine Becker, or Kate Becker. She is a doctor already. So Dr. Becker is a PhD who did her Bachelor of Science at University of Michigan and completed her PhD in May of 2022. And now she's an MD candidate at University of Toledo. So she's going to be speaking about glioblastomas today. Thank you, Kate.
Thank you for the introduction. I appreciate it. So I am going to just share my screen here and I will get started. So thanks so much for having me. I'm excited to talk to you all this morning about some of the things that I've worked on over the last several years, which is targeting glioblastoma tumor microtube networks via MDF formans. And it's always a treat for me to speak to a neurosurgical crowd because this is a group of people who are very, very familiar with the natural history of glioblastoma. So I won't spend too much time here. I think we all probably know that this is the most common type of primary brain malignancy. It's a very aggressive disease with very poor outcomes. That does not have very good treatment options, and there remains no standard of care for recurrence for many years now. What you might not be as familiar with is something called the glioblastoma tumor microtube. And this is a specific structure on the glioblastoma cell. They are ultra long membrane tubes, so you can think of them kind of similarly to a glioblastoma neurite. And they function as dynamic probes of the invasive front, kind of extending and retracting in response to environmental cues. Alternatively, they can be quite long-lived and interconnect GBM cells into a network of tumor cells that functions very syncytially to support the health of the tumor. They are actin and microtubule enriched, so they're fundamentally made up of those same building blocks that make up all cellular structures. They are very associated with the GBM stem cell compartment, and they have been identified as the structure that participates in the neuron to glioma synapse. And in the context of all of these things, they're highly implicated in both GBM invasion and therapy resistance. And you can see some examples of what those networks can look like over here on the left in my images. On the top, we have some pictures from my own cell cultures. And on the bottom, we have kind of a cartoon schematic of what all those interconnected components can look like within the cellular tumor milieu. So to put a little bit finer point on what I mean when I say that these structures are highly implicated in GBM therapy resistance, we know from some really very elegant studies from Frank Winkler's group out of the University of Heidelberg that GBM cells that are connected to the tumor microtube network are overwhelmingly the cells that survive both radio and chemotherapy. So we can see in the top panel here that the starred cells on the left are cells that are not connected to the network. This arrowed cell in the middle is a cell that is connected, and we see tumor microtubes coming out of it. After 7 days of radiation, the starred cells are significantly diminished, whereas the arrowed cell is very much so reinforced and still alive. The same can be said for temozolomide treatment. On the bottom here, on the left panel, starred cells are not connected to the network, whereas arrowed cells are. After 21 days of temozolomide treatment, we see no starred unconnected cells left and strong reinforcement of the connected cells. Perhaps even more interesting to this particular group, and as neurosurgically minded people, tumor microtubes have been implicated in post-surgical recurrence of GBM. So we know from observational data that the majority of GBMs recur within 2 centimeters of that primary resection margin, which is a very interesting observation because that's also the area that we most intensively target with postoperative radiation therapy. And what this study showed is that physically removing or surgically resecting cells that are connected to that tumor microtube network, or severing those ties between connected cells, prompts the network to redirect its invasive trajectory towards the resection margin in the connected cells that are left behind. And you can see over the course of 28 days here, where they leach into this area, that the cells that are connected to the network with this arrow extend new tumor microtubes into the resection bed and subsequently go on to repopulate that area. So that leads me into talking about my PhD work. And my PhD work really had two pillars to it. So on the one hand, I worked very hard on building a patient-derived primary CNS tumor live cell biobank, and that involved everything from identifying and consenting patients to attending and often scrubbing for the operations, collecting the samples, taking them back to the lab, and processing them into cell lines that I then subsequently used for my experiments, looking at the cytoskeletal dynamics of tumor microtubes in these patient-derived cell lines. And I know that everyone on this call has probably at least at some point had some basic cell biology, but just as a quick refresher. So the cytoskeleton of the cell is made up of three independent systems, that being the actin, the microtubule, and the intermediate filament systems. And those systems are controlled by the Rho family of GTPases, which are ubiquitous proteins in the cell that are activated in response to environmental cues and then subsequently exert their control over cytoskeletal systems through downstream effector proteins that they activate at different localization sites. And one of those downstream effector proteins is the MDF-formins. So MDF-formins are the largest family of downstream effectors for Rho GTPases. They function as both nucleators and polymerizers of linear actin filaments, and then they also have independent roles in stabilizing microtubule arrays. So importantly, they act on two out of those three cytoskeletal systems, which positions them in a bit of a unique place within the cytoskeletal protein network, because most effector proteins only can target one of those systems. But as you can see in this schematic, they function in many different things around the cell in that role. Anything that involves reorganization of the cytoskeleton, in particular the actin cytoskeleton, so things like endocytosis, any form of protrusive structures, or cell or cell matrix adhesions, transcription, trafficking within the cell, or cell division. And this is a animation of what that protein looks like in action. So you can see that it's able to sort of bring together the first few actin monomers, and then it subsequently slides along the filament as it builds. And independently to this, again, I'll reiterate that it has independent roles in stabilizing microtubules. So what we found is that by using small molecule drugs that target MDF-formins, that we were able to significantly block GBM invasion in patient-derived 3D invasion assays and also prevent tumor microtube formation. So you can see on the left in our vehicle-treated assays that these cells are robustly invading the 3D matrix. At the 96-hour time point, we see long extended tumor microtubes overlapping and interconnected at the invasive edge. In contrast, our IMMO2, or our MDF-formin targeting compound, we see almost no invasion of the matrix over our time lapse, and we see balding of the invasive edge with no quantifiable tumor microtubes associated with that. And that's a very exciting discovery, because we know that these things are very involved in the therapy resistance of GBM, like I reviewed earlier. But we also know from a clinical standpoint that that's really not quite enough, because by the time that any of our GBM patients present for clinical care, they already have a tumor that has robustly and diffusely invaded their brain parenchyma, and we need to have something that is going to address networks that already exist. And so to start investigating that question, we designed an experiment where we embedded patient-derived spheres in a matrix, allowed them to invade untreated for 48 hours, and then subsequently treated them with our compound. And what we found was that by targeting MDA with these small molecules, we were able to eliminate the tumor microtubes that already exist. And in the sake of brevity, I didn't include all of the data here, but it also sensitized these cells to both radiation and temozolomide treatment by eliminating those in this context. So what we're working on now is trying to understand the exact mechanism of how this is happening. So we have made a very exciting phenotypic observation. We know the protein that our drugs are targeting. We know that that protein is very involved in cytoskeletal dynamics and a lot of important fundamental processes in the cell, but we also know that it interacts with a lot of other proteins. So what we're doing is integrating our transcriptomic and kinomic analysis now to create an integrated model, a multi-omic model, and trying to identify exactly what changes are happening that associate this phenotype change that we're seeing. And that's what I'm really excited to be working on in my research time as a fourth year. So with that, I will finish up and say thank you to the many people who have helped me along the way, and thank you all for hosting me these last few weeks. I've had a really great time on service with you. Happy to take any questions.
Thank you, Kate. And your brevity is always appreciated too, so that's great. Any questions from the audience, either in the chat or just chime in? Otherwise, you can reach out to Kate on your own. But let's continue on then if there aren't any questions. You guys can switch over if you don't mind. And our next speaker is Alice Shu. She completed her BA at Dartmouth and majored in mathematics. She's now at Emory, her MD candidate. And she is going to be speaking about deep learning and one of my favorite subjects, subarachnoid hemorrhages. So thank you, Alice.
Thank you, Dr. Kim. Good morning, everyone. My name is Alice. Today I'll be talking about applying deep learning to neurocritical care and aneurysmal subarachnoid hemorrhages. So this is just a slide about me. This is everything that Dr. Kim has already said. Today, the objectives will be to pinpoint areas in the hospital course of the patient with an aneurysmal subarachnoid hemorrhage where deep learning prediction can be applied. We'll broadly articulate the structure of our deep learning model and then summarize the results of the trained model and propose a few future directions for this project. So deep learning has been used in critical care in the past, mostly to predict sepsis, AKI, and death. And this is just a sampling of papers that I found from a brief search. And here, but I don't think it's, for the most part, these papers train models based only on EMR data. Or if they included imaging, they included scores derived from imaging data that aimed to condense all that information into one just like simple digit so that they could include it into their model. And so for our model, we wanted to kind of expand on that, particularly in the neurocritical care setting, and use more than just a single digit so that we had more information to work off of to train our model on. So this, as we all know, as neurosurgeons, is the timeline of the aneurysmal subarachnoid hemorrhage. The first 24 hours are really critical to their care. When the patient first presents to the ED with the worst headache of their life, they get their workup, they're admitted to the neuro ICU, and then they're monitored very intensely before ultimately they have some kind of discharge status, whether or not it's going home, going to a SNF, or a lot of patients actually end up dying or on hospice. So the goal for our model is threefold. We want to predict the incidence of vasospasm. We want to predict the rate of VPS placement or whether or not someone should get a shunt, as well as their disposition status. So that's highlighted here with our 3 red stars. And then these are all the variables that we have included into our model. There are a lot of them. And in particular, I want to point out that we use the patient's presentation non-contrast head CT as the imaging component of the data set. And so what our model does, this is a schematic of our model. Our model concatenates the advantages from a dense neural net and a residual neural net to learn from both data that we can get from EPIC and imaging data that we obtain within the first 24 to 72 hours of the patient's arrival. So here you can see that the imaging data is fed into the residual network, and then the patient's EMR data is fed into their dense neural net. And then they're combined via a dropout function into a concatenation layer that then processes the data into some rough matrix that we can then analyze for accuracy, and a few other things that I'll talk about later. And our goal with this model is to get some kind of outcome prediction data while we minimize the loss of data as the images as the data gets passed through our model. And so we can do that with the dropout function, which kind of blinds is the wrong term, but essentially drops part of our data set and uses the remainder of our data set to bootstrap its way into a new a kind of modified data set is still within the parameters of our demographic, but kind of beef up the model a little bit more, so that we can make better predictions. And so predictably, patients who have received EVDs on admission were much sicker than those who did not. They were more likely to have higher Hunt-Hess scores, higher WFNS scores. They were more likely to have a CT angiogram positive for an aneurysmal subarachnoid hemorrhage, as well as more and then surprisingly, I think the patients with EVDs were more likely to have hypertension, but they were not more likely to have any other of the comorbidities when we looked at the data set. And they were also more likely to have complications. And our model works really well. So we looked at accuracy, as I kind of alluded to before. We also looked at the residual operating characteristic area under the curve. And we also looked at the F1 score, which is how good the model is at remembering all the possible answers that it was given and then picking the right one. And so I have included the equations in the corner down there if you want to look at it. So in terms of our first goal to predicting the likelihood of in-hospital vasospasm, our model is actually quite good at it. The accuracy is quite high, the raw characteristic is quite high, and the F1 score is quite high. And one advantage to our model is that we only included variables that were discrete compared to other studies, which included lab values such as cell counts and vitals and sodium, which change over time and change often quite quickly. In terms of the VP shunt placement, our model is actually very accurate at predicting whether or not a patient should get a VP shunt. However, it's not very precise. So as you can see here, the accuracy is high compared to the F1 score, which is a 0.6 thereabouts. So it's very good at predicting when you need a shunt, but our model will also give you a lot of false positives. And we hypothesize that this probably comes from a variety of different factors, some including seasonal variation or surgical decision-making or even family decision-making, where a family might decide to go in the comfort care route before we even have the opportunity to place a shunt. And in general, because our data set is based on our institution's patient demographic, our cultural decision making is we tend to be more aggressive in terms of placing EVDs, and so our shunt rate might be lower in comparison to other places. And in terms of disposition status, our model is very good at predicting disposition status. It's quite accurate, and its F1 score is really high. However, we only looked whether or not our disposition was good or bad, and good meant that they were going home or they were going home with home health, and bad was pretty much everything else. So one place where we think that we could improve this model is to look at it train our model on a more look at more options, and so look at whether or not there is a difference between patients going home without home health versus with home health, versus if they were going home if they weren't going home, if they were going to inpatient rehab or SNF or otherwise. And so in terms of future directions, there's more room to increase the precision and granularity of medical decision-making. We want to do some more subgroup analysis to explore more some of the unexplained variants within our complication categories. We want to assess the model against clinician judgment to see if it holds up against seasoned surgeons in their decision making, as well as generalize the model to other neurocritical care problems that I've listed a few of them here. These are my references, and I want to give a quick thank you to everybody who's helped me so far. Dr. Kim, I think you're muted.
Sorry, I was just on the phone. Apologize. Thank you for your presentation. Fantastic. Are there any questions? Either chime in or in the chat box. Okay, then we'll move on to our next speaker then. If you guys could switch over again, that'd be great. Our next speaker is Lily McLaughlin. She hails from Villanova, where she was a biology major. Went to Drexel and completed her Master's of Science in Biomedical Studies, and now is at Georgetown, where I believe Nate Nair, our graduate, is the program director. So I think she's going to be speaking about the evolution of the NOMS decision framework with the SORG Nomogram. So thank you, Lily.
Thank you, Dr. Kim. And yes, Dr. Nair is there. He had wonderful words to speak of you guys, and that's really one of the main reasons that I'm here, and it's been a great month so far. And so now just to get started, good morning, everyone. My name is Lily. It's a pleasure speaking with you this morning. My talk for today is entitled The Evolution of the NOMS Decision Framework with the SORG Nomogram. And so I'm going to start with just a brief background on metastatic spinal tumors and the NOMS framework. And then I'm just going to introduce a case that we can refer to as we review the SORG Nomogram. And I'll hopefully end with some key takeaways that I hope you'll find useful in your daily practice. So really, why should we care about this topic? It's estimated that up to 70% of cancer patients are affected by spinal metastases. And so from this map here, we can see with the most recent data, which is from 2017, that 5.4% of the US population had cancer. At that time, the US population was approximately 325 million people, meaning that over 17 million people had cancer and over 12 million people could be affected by spine mets. So this is a huge patient population that you're likely to encounter, especially for you guys up at the U. And it's also important to note that these numbers are just likely to continue to increase thanks to advancements in both imaging as well as in systemic treatment options, specifically immunotherapy. And now, before we dive into the NOMS framework, it's important to also remember that our goal with these patients is always going to be palliation. We aren't aiming for a cure here. We want to get these patients out of pain, preserve neurofunction, and overall really just ensure that they're having the highest quality of life possible. So what's the NOMS framework? It's this comprehensive approach used really for the management of metastatic spinal tumors. It utilizes these 4 points of assessment, the N, the O, the M, and the S, to determine what's the optimal combination of systemic therapy, radiation, and surgery. For N, the neurologic, we're looking at the degree of epidural spinal cord compression and the presence of any neurodeficits. For O, oncologic, we're exploring the responsiveness of the primary tumor type to treatment, specifically conventional radiation. For M, mechanical, we're evaluating the stability of the vertebral column using the spinal instability neoplastic score. And then for systemic, the S, we're really looking at the broader picture here in terms of the patient's overall health and really what's their long-term prognosis. So now I'd like to just briefly introduce a case that we're going to follow along with for the remainder of the presentation. This is a 47-year-old female with a history of angiosarcoma of the breast, who's now presenting with 5 months of back pain that's acutely worsened over the last week. She's now having difficulty sleeping at night and having to sleep in a recliner, and she's also having pain that's worse with lying flat and with movement. Otherwise, her vital signs are normal. She's neuro intact, 5 out of 5 strength throughout, and able to walk unassisted. Workup begins, and our MRI of the total spine demonstrates this T5 osseous metastasis, and we can see a plain and burst fracture here. There's also some concern noted for some cord signal change. So now, if we start taking this patient through the NOMS framework, neurologically, We have an epidural extension of tumor with what I'd say is probably an ESCC grade 3 compression or a Bilski score 3. Oncologically, we have this historically highly resistant tumor type with our sarcoma. And then mechanically, we have this T5 lytic lesion. We have mechanical pain, which is demonstrated by the patient's inability to lie flat in bed at night and that pain with movement. We have a segmental new kyphosis secondary to that T5 burst fracture, almost complete collapse of the vertebral body, and then bilateral posterior element involvement, which all in all results in a SIN score of 14, also known as an unstable spine. So what does the NOMS framework tell us about our patient? Well, first, we have this high-grade core compression from a radio-resistant tumor. So we're going to need separation surgery to really ensure that we have adequate space between the tumor and the cord so we can deliver a high enough dose of radiation for local control. Second, we have that SIN score of 14, which is really demonstrating the need for some sort of stabilization, whether that's, an open posterior fusion, perc screws, etc. And lastly, what we really haven't touched on yet, and what the SORG nomogram is going to help us out with, is the systemic category. Are the benefits of the surgery really going to outweigh the possible risks? And will we add meaningful time to this patient's life really without taking away any of its quality? So to help us start to answer that question, I'd like to share with you this paper that I worked on during my time at Memorial Sloan Kettering Cancer Center. It was a retrospective validation study with the primary aim being to assess whether the nomogram and classic algorithm, which were both created by the Spinal Oncology Research Group, known as SORG out of Mass Gen, accurately predicted 1, 3, and 12-month survival in patients with metastatic spinal tumors. And the group that I worked with at MSK provided this external patient population. Overall, any patient 18 years or older who had surgery for a spine met and had a minimum of a 12-month follow-up was pulled via a data line request, and the first 100 consecutive patients that met criteria were included. So here on this slide, we can see the SORG's classic algorithm on the left and then the nomogram over on the right. The algorithm doesn't accommodate for continuous variables and really just divides patients based on the total number of points that they accumulate. It's very similar to a lot of the previously established algorithms that are used in clinical practice. However, the nomogram, which we see here, is a figure that actually sets prognostic factors to this common point scale, which we can see right here. And it also accommodates continuous variables and then translates that score into an individual survival probability. And this is really what the major advantage is, because a lot of the previously used algorithms couldn't predict individual survival times. So in terms of results, the algorithms were considered accurate if the area under the curve of our receiver operating characteristics analysis was greater than 0.7, and they're noted on this slide by the orange asterisks. But the most important ones to note are the nomogram for the 3-month survival with an area under the curve of 0.74 and 12-month survival with an area under the curve of 0.78. Additionally, the nomogram's 3-month and 12-month predictions were noted to outperform the other algorithms with p-values of 0.009 and 0.033 respectively. Here, we can take a look at the nomogram's ROC curves for the 3-month and 12-month survival, as well as how it compared to the predictive accuracy with those other well-known algorithms. And here we can see that in both graphs, the nomogram, which is denoted by that maroon curve, is outperforming the other algorithms. So some limitations of the study are just mainly centered around the generalizability. First, patients who underwent non-surgical or some more conservative treatment options were not included. Additionally, our patients were only operated on by 2 surgeons at a single institution who likely shared similar decision-making when it came to bringing the patients to the OR. And lastly, the 2 hospitals, Mass Gen and MSK, are fairly close to one another in terms of geographic distance, so this may not represent a diverse enough patient population. So now, just to kind of wrap things up, we want to go back to our patient to finish out the S of the NOMS framework using the SORG nomogram. Our patient had a hemoglobin of 8.6, a white blood cell count of 6.8. She's 47. She has had some previous systemic therapy. She has lung mets, more than 1 mobile spine met. Primary tumor type was angiosarcoma, and she had an ECOG score of 2. Coming to a total points value of 309. And therefore, for our systemic aspect of NOMS, the nomogram is telling us that our patient has over a 60% chance of surviving 3 months and a less than 30% chance of surviving a year. Ultimately, this patient did undergo T4 to 5 LAMI with resection of epidural tumor and then posterior fixation from T4 to 7, and then did get some adjuvant radiation SRS in the form of 30 gray and 3 in that same area. But what's really important to note here is that for our patient, her main concern pre-op was being able to get home to Ecuador to her family, really for whatever time she had left. And ultimately, she did make it back before that 1 month post-op and was lost to follow-up because of the travel. But, hopefully able to be there with her family for whatever time she had left. So therefore, had this nomogram been utilized during the treatment decision-making process, knowing that patient had over a 60% chance of surviving 3 months may have been helpful, and a great enough chance to proceed with surgery to get her home to her family. So I'd just like to end with some key takeaways for you guys. First, again, like we said earlier, the number of metastatic spinal tumors is just going to continue to increase because patients are living longer, mostly secondary to advancements in systemic treatment. Additionally, because of that, medical oncologists are likely going to keep pushing for more surgery because they're just going to keep having more treatment options, and they need their patients out of pain in order to undergo them. Most importantly, I think, the SORG nomogram is really just another tool for physicians to use, really to help determine what the best treatment option is for their patient. But ultimately, it is always going to come down to clinical judgment. So, it's just another tool in your toolbox. This isn't and never will be a hard and fast rule. For instance, we're not going to ever say that a 3-month predicted survival of 70% or greater means you absolutely take your patient to the OR, or a 30% chance means there's no way that you do that. It's never going to be something like, a hemoglobin dropped below 7, let's give them a unit of blood. And lastly, just one thing to remember is that our SORG nomogram does predict the 3-month and 12-month survival accurately, but not 1-month survival. And that's all I have for you guys today. Thank you so much. Happy to answer any questions.
Thank you, Lily. Great talks so far. Really impressed with the time management too, everybody. Thank you. Any questions in the chat box, or just chime in? It's a quiet audience today for some reason. But okay. Thank you so much. So we'll go on to our last speaker, Joanna Tabor. Just pull up your CV here. Joanna did her undergraduate at NYU. She majored in neuroscience and has then stayed in the New York area, now at SUNY Downstate. And she's going to be speaking to us today about clinical and genomic differences in supratentorial versus infratentorial NF2 mutant meningiomas, a topic that's going to be of great interest in this group. Thank you.
Thank you, Dr. Kim, for the introduction. And thank you, everybody, for a great sub-I. I've had a really great month working with all the attendings and residents. So today I'm going to be talking about some work I did over my research year at Yale with Dr. Moliterno-Cannell about the genomics of infratentorial versus supratentorial NF2 mutant meningiomas. So just for some background, as we all know, meningiomas are the most common primary CNS tumor, and they really demonstrate a significant variability in their clinical behavior. So we see that some histologically confirmed WHO grade 1 meningiomas actually behave more like their grade 2 counterparts with higher recurrence rates, and this isn't well characterized or captured by the histologic framework of the old WHO grading criteria. Recently, the WHO 2021 grading criteria now includes genomic information for classification of meningiomas, such that TERT promoter mutations and homozygous lesions of CDKN2A and B are now enough to classify meningioma as grade 3. So some really important work over the past decade, primarily done by the Cannell lab at Yale and others, really elucidates the somatic mutations that underlie sporadic meningioma formation. The most common somatic mutation is NF2, which is found on chromosome 22, and it accounts for about 50% of all sporadic meningiomas. And it's really part of the aggressive meningioma pathway, whereas the other non-NF2 mutations, such as TRAF7, POLR2A, KLF4, are less aggressive. And importantly, the NF2 meningiomas that have chromosomal instability or co-mutations in SMARCB1 are really the ones that become aggressive. So this genomic framework really helps us understand some of the variability in this meningioma behavior that isn't captured by histology. So over the past decade or so, we've looked at some clinical correlations of various genomic subtypes. And we find that they really have very distinct clinical behavior. NF2 mutant meningiomas specifically are more aggressive, as I mentioned. They tend to be more common in males, where meningiomas usually present in females. They tend to be largest at presentation and present at an older age, and they're really more high grade with a higher proliferative index. They also are associated with seizures, and radiomic studies find that they are associated with bony involvement and also invasion of the sphenoid wing. So they really do have this distinct clinical picture from other subtypes. And another really important correlation of these genomic subtypes is with their location. So we find that there's distinct correlations with specific location for meningioma subtypes. NF2 meningiomas occur preferentially along the convexity and tend to rise posterior to the coronal suture. And they really display a laterality preference, both along the convexity and the skull base. Whereas NF2 mutations that co-occur with SMARCB1 tend to occur along the midline. The other mutations, such as POLR2A, TRAF7, and Hedgehog, really prefer the skull base. But not all of this variability is accounted for by genomic subtypes. We find that generally meningioma outcomes vary according to their location, both non-skull base versus skull base, and infratentorial versus supratentorial. So we know that infratentorial meningiomas really are quite rare. There's only 10% of them, but they are shown to have less mass effect and edema in the few studies that are out there. And just skull-based meningiomas in general have less mass effect and have lower rates of recurrence despite decreased extent of resection. So what we wanted to look at was whether these NF2 mutant meningiomas, which are really known to be more aggressive, have any differences in their clinical and genomic behavior when looking at their location relative to the tentorium. So our cohort consisted of 191 NF2 mutant meningiomas. We included those that had whole exome sequencing or targeted sequencing showing a somatic NF2 driver mutation from surgeries from January 2012 to September 2021. We excluded those that had germline mutations, co-mutations in SMARCB1 because those are a distinct subtype, those that are radiation-induced, loss follow-up, and non-primary. So in the end, we had 165 supratentorial meningiomas and 26 infratentorial, which really reflects the trends that we see. Our cohort generally reflected what you would expect in a meningioma cohort. So we had a majority of white patients and female patients. Most of our tumors were supratentorial and low grade and did not recur, and we had a median follow-up time of 24.7 months. When we compared the supratentorial versus infratentorial meningiomas, looking at their clinical characteristics, we find that both age and gender distribution is really the same between the two groups, but where they differ is in their symptomatology at presentation. So maybe unsurprisingly, the infratentorial meningiomas tend to be more symptomatic at presentation. Specifically, these patients present with changes in hearing, nausea, and vertigo, which are things that we expect of tumors in the posterior fossa. And they're also less likely to undergo gross total resection. But interestingly, we find that even though these tumors do undergo subtotal resection more often, they don't recur more often. So there are no differences in recurrence rates between these two groups, despite a difference in extent of resection. And further, these meningiomas really are more benign clinically compared to the supratentorial ones. So the infratentorial ones generally just have a lower proliferative index. They are lower grade. In fact, we only had one high grade infratentorial meningioma. They're smaller in size and also have less edema. And these differences are also reflected genomically. So we find that the infratentorial tumors are also genomically benign. So they have a lower percentage of aggressive chromosomal aberrations characterized by chromosome 1p loss, and also have less chromosomal instability characterized by fraction of genome altered. They also are trending towards a lower number of somatic mutations. So we wanted to make sure that this difference isn't confounded by grade, since we did see a significant correlation with grade. So when looking only amongst grade 1 tumors, we find that infratentorial ones still have less chromosomal instability compared to their supratentorial counterparts, really highlighting the difference in their genomic behavior. And these are just some Kaplan-Meier curves showing that even despite the fact that there's a difference in extent of resection, the overall survival and the progression-free survival for these two groups is not significantly different. So what are the clinical applications of this work? I think part of it is kind of having a way to understand the prognosis of these tumors when we have them present. So I think when first looking at these two different patients, you would be inclined to think that the top tier is the one that is less worrisome, a frontal convexity meningioma, compared to this large posterior fossa meningioma that's causing some compression of the brainstem as well as a transverse sinus involvement. But when we look at the genomic analysis, we find that it's this frontal convexity one that really doesn't look so concerning, especially surgically, is the one that is more molecularly concerning. So on histological analysis, this is an atypical meningioma, grade 2. And on genomic analysis, we find that it really has remarkable genomic instability. It has 65% of its genome altered with loss of heterozygosity. Whereas this large posterior fossa meningioma is only a grade 1 and only has this one somatic mutation in NF2. So some conclusions for this work. So as we know, NF2 mutant meningiomas are more aggressive. However, it seems that this association doesn't really apply broadly throughout the entirety of the location presentation of these tumors, such that the infratentorial ones don't behave like the supratentorial ones and don't display this characteristic higher aggression that is associated with the subtype. So these infratentorial ones have smaller tumor volume, less edema, lower grade, and lower proliferative indices. And this really reflects the studies that show that skull-based meningiomas in general are just less aggressive compared to the non-skull-based ones. And so I think that our results kind of underscore that the goals of infratentorial meningioma surgery should always be maximal safe resection. And when there is residual, surgeons may be reassured that these tumors really don't tend to recur compared to their supratentorial counterparts, despite the more aggressive genomic subtype. So some limitations of our study is, of course, that we only looked at NF2 mutant meningiomas. This was mostly due to the sample size. So we only had the 26 infratentorial, despite a large database of over 670 meningiomas that we have. So some things we're looking to do in the future is to have a multi-institutional collaboration for larger sample sizes so that we can include the other genomic subgroups and see if this difference also occurs there. Also, our small sample size of infratentorial meningiomas precluded us from looking at other clinical variables of interest. Particularly, we're interested in post-op radiation and whether there's any difference in outcome there, which may also have a clinical implication for the treatment of these tumors. And we had a relatively short follow-up time for our meningioma study of 24.7 months. So we also are looking forward to having a longer follow-up time. So I just wanted to acknowledge all the people who worked on this study, specifically the guidance of Dr. Moliterno and the Moliterno and Ganell labs. And I want to thank everybody for listening to my talk. And any questions?
Hi, Joanna. Jake Ruzovic here. Just want to say thank you to you and all the students so far that have given their talks. They've all been wonderful. I think we're learning, from your presentation and from some of the work in Dr. Ferreira's lab and others that the WHO classification system of these tumors is woefully inadequate at predicting their biologic activity. And just wondering, your take on other methods and beyond just looking at the somatic or individual tumors, genetic makeup that might, help predict their biological activity, whether it's the proteome, the methylome, anything else that we can correlate with a tumor's biologic activity.
Yeah, so there have been quite a few studies recently about the methylation status of meningiomas that also predict their occurrence. So I think several different groups have been looking at creating a schematic for including both the genomic underpinnings as well as the methylation status and their histology to better characterize. So I think that's really promising. And then also some machine learning and radiomics is also helping kind of predict how these meningiomas will behave. So I think there's a lot to look forward to in that regard.
Thanks so much.
Great presentations. Any other questions? I just have one last question for Joanna. Does the Yale group change their follow-up imaging routine based on biology?
So we haven't, I mean, we do genomics for every single patient that has their tumor resected, and we discuss it at tumor board. So we do change their follow-up based on the genomics, yeah. Especially if there's a concerning subtype and they have a shorter follow-up time.
Interesting. Great. Well, we're at the end of our 4 speakers, and